Friends, in this particular video, I'd like to talk on fracture healing, which is a very interesting and emerging process that involves the cellular pathways and the molecular pathways in a very interesting and controlled manner. And this is very important to understand because this can guide us to treat the fractures better. So I'll try to outline the anatomy of the bone, in relation to fracture healing and the various phases of fracture healing, and talk on direct as well as indirect fracture healing that we see in absolute stability and relative stability, respectively. And we'll also talk on the factors that can positively or negatively affect the fracture healing processes, which can lead to non-union, delayed union, and malunion. So if you see the bone, it is basically a composite material, which is calcium hydroxyapatite. And the hard bone is the cortical bone, and the softer, more porous type of bone is the cancellous bone, which can have different type of healing processes. The periosteum is very important, and blood supply that will bring in the nutrients for healing are essential for healing. So we basically, the bone that are involved should have good healing biology, and the bones that are fractured, they should attain some kind of biomechanical stability over a period of time so that there can be a good healing of the fracture. Now, cancellous bones are trabecular and spongy, and only 20% of its actual volumes of bone mass, and they are highly vascular, and they are very good in healing themselves because they are vascular and they have got a lot of porosities. Possibly this allows attachments of various cells that are important for healing of the fracture. Relative stability, as we know, can happen when you do a close reduction and plaster application or traction, or intramedullary nail or a breech plating, or as against to the absolute stability when you apply leg screw or do an open reduction internal fixation with a plate under compression. So this leads to direct bone healing in absolute stability, whereas in the relative stability, there is formation of indirect bone healing with formation of callus. So periosteum has two layers, one outer fibrous layer and an inner cambium layer, which is highly cellular and very active in healing of the fracture. If you see the natural healing of fractures in cortical bone in a plaster application, it is essentially a kind of endochondral ossification when there is a cartilage template and there is cell differentiation, and finally there is ossification. So which is similar to the process of endochondral ossification. As compared to cancellous bone or certain bones like clavicle, which is partly membranous, can lead to a membranous ossification where there is invasion of the pre-existing tissues with blood vessel, and there is formation of periosteum, and finally formation of bone and union of the bone or calcification. Now, these are the four phases of fracture healing, which are traditionally described according to AO: the phase of inflammation, soft callus formation, hard callus formation, and remodeling. So in the first week, the hematoma and inflammation stage, then comes in the 2 to 3 weeks time, the formation of soft callus, then the hard callus that happens after a month and can go up to 4 months, and it can go beyond 4 months. There is and up to years, actually. It can be the remodeling phase where there is a reestablishment of the medullary canal and removal of excessive bone which are lying outside the normal bone contour. Now, there is a strong cellular participation. You can see some overlapping of these stages. They are not watertight compartment of phases. So there is migration immune cells of mesenchymal cells, and then the cell differentiation to chondrocytes, then participation of the osteoblasts, and later on in remodeling phase, osteoclast and osteoblast, which gradually forms from a granulation tissue to cartilaginous osteoid, then woven bone in hard callus, and finally lamellar bone in formation of the bone remodeling. And there is a lot of biomolecular process, the biomarkers like tumor necrotic factor, interleukin, etc., which are important in recruitment, induction, proliferation, and differentiation, and finally bone formation. So personality of the fracture is important, not only the geometry of the fracture, but also the status of the soft tissue, which are in fact the mother for healing beyond the bone as well. So neurovascular status of the limb is also equally important. So if you see the inflammatory phase in the first week, there's a hematoma formation, as you all know, the rupture of the periosteum, rupture of blood vessels. The cells then migrate into this fracture hematoma because this soft tissue is damaged and blood vessel disrupted, and there's separation of the bone, and the hematoma becomes a mother, kind of unit that helps in healing. So once the injury occurs, the natural process of bone healing begins with the creation of soft callus, which is a cascade of cellular differentiation, as I said earlier. If we see the subphase of this soft callus, first subphase is new blood vessel invades the organized hematoma. There is decrease in pain and swelling. In subphase 2, the fibroblasts derived from the periosteum, the cambium layer, invade and colonize the hematoma next. Then in subphase 3, the fibroblast produces collagen fibers, which leads to a formation of granulation tissue. Then in subphase 4, the collagen fibers are loosely linked to the bone fragment. They become kind of sticky, and there is less mobility as compared to the beginning. And in subphase 5, the cells of the granulation tissue gradually differentiate to form the fibrous tissue, and finally the fibrocartilage. That means the hematoma is gradually replaced by fibrocartilage, like a cartilage model of endochondral ossification. Now the phase of hard callus comes, which is actually an endochondral ossification that converts this fibrocartilaginous soft callus to woven bone. This starts at the periphery, goes centripetally, going from periphery, moves toward the center, further stiffening the healing tissue. This continues until there is no more interfragmentary movement and stability is attained at the fracture. So this is how the soft callus finally converts to hard callus with formation of the woven bone over the lattice of collagen and fibrocartilage. Now in the remodeling, there is conversion of woven bone into lamellar bone, the architecture of lamellae, through surface erosion and osteonal remodeling. This occurs once the interfragmentary movement ceases to exist in the fracture site. Fracture healing becomes complete with remodeling of the medullary canal and removal of the parts of external callus, which are little exuberant than required. So as I said, fracture healing is triggered by breaking of the bone itself, the complexity of the fracture, the extent of soft tissue injury, whether the closed or open fracture, or how much periosteal stripping is there, and overall health condition of the patient are all determinant of how the fracture is going to heal. There may be healing problem in open fracture, or there can be delayed union and non-union for various causes, even in indirect bone healing. Now coming to absolute stability and direct bone healing, here the coordinated action of the osteoclast and osteoblasts, they actually form what is known as the cutting cone, which is like a micro drilling through one side or one fragment of the bone to the other fragment of the bone, because there is absolute stability, there is no gap. So indeed, the direct bone healing is an accelerated bone remodeling, which takes a little shorter time than the formation of callus. And in direct bone healing, there is no callus formation. If you see primary bone healing, there is no callus formation, direct cutting cone and direct bone formation. That's why it is called direct healing. And in secondary bone healing, you have hematoma formation, then cartilage formation, the endochondral ossification, osteoid and callus formation. So in this picture, you can see where there is a direct healing because of good contact of one cortex. On the other side, there is gap healing. So this is direct healing, this will be indirect healing. So cutting cones are important in primary and direct healing. Callus is important for secondary healing. In indirect healing, the gap healing in complex fracture, there will be indirect healing with callus. Now, good bone biology of fracture healing and good biomechanics. If both have a good marriage, then usually the fracture heals uneventfully. So there are a few C's that I want to tell you again. How is the soft tissue coverage? Whether there is any contamination depending on closed or open fracture, whether the bone is cancellous or cortical, whether there is a good contact between the fragments, whether there is a good compression across the fracture site, whether there are good circulation around the limb and the fracture unit, and whether the age is favorable, or whether there is unfavorable factors like cigarette smoking or a pathological fracture. These have a big bearing in fracture union as well. So with this, I thank you. So in summary, I would say the most of the fracture can heal with an indirect bone healing with the 4 phases that we have seen in fracture healing. And the cases or fractures where we attain absolute stability, either by compression plate or interfragmentary fixation, we see direct bone healing, which is a much shorter pathway. Thank you.